Thank you for your patience.
So good afternoon, everyone, and thank you for joining us today for our it's actually our third workshop for this rulemaking. I am Amelia Boyd, and I am the program manager for the commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime this week on our YouTube channel. Please note that I do have a visual impairment, and so for accessibility, documents we'll be reviewing today may be displayed in larger font and in dark mode. This means the background will be black and the text will be white. All the documents we'll be discussing today are included in the workshop materials available on the Rules in Progress page of our website, which is wmc.wa.gov. So panelists and attendees, you may unmute yourselves and share your webcam. Attendees, if you have a question or would like to make a comment, please use the raise hand function, and we will get to your questions and comments as quickly as possible. When offering comments, please avoid reading aloud any written remarks that are already included in the materials. And then please note that these workshops are intended to be collaborative with a back and forth exchange of ideas about the proposed language. And I will now begin the roll call of panelists and staff. When I call your name, please introduce yourself. So we'll start with Ed since he's on the phone. Ed, go ahead and introduce yourself.
Hi there, Ed Lopez, Commission member.
Thank you. Marlon.
Good afternoon, everyone. I'm Marlon Basco. I'm a policy analyst at the Department of Health, and I support Amelia and the Commission with rules work.
Thank you. Dr. Chang.
Hi, Poshin Chang. I'm a family physician or retired family physician. I'm a commissioner on the commission.
And Bonnie is a new employee in the commission, and she is here as our co-organizer. So Bonnie, go ahead and introduce yourself, please.
Hi there. Yes, Bonnie Gregory. I am the new AA3 with the commission, and I am here to help primarily Amelia, but everybody here. So thanks for welcoming me. I appreciate it.
Thank you. Heather.
Yeah, good afternoon. Heather Carter. I'm an assistant attorney general, and I am the legal advisor to the commission.
Kyle.
Good afternoon. My name is Kyle Kiernan. I'm the executive director for the commission. I'm also on site here at the Department of Health in Tumwater.
And thank you for being there, Kyle. And Dr. Domino, if you'd like to go ahead and introduce yourself and then start the script.
Hi, good afternoon, everyone. I'm Karen Domino, and I'll be the presiding officer for this rules workshop today. I'm a commissioner on the commission. And today is Monday, September 22nd, 2025. And according to my computer, it is 1:17 p.m. This meeting is being held via Teams webinar and in person at the Department of Health Town Center 2, room 166, located at 111 Israel Road, Southeast in Tumwater, Washington. The rule being discussed today is regarding opioid prescribing general provisions in both Chapter 246-918 WAC for physician assistants and Chapter 246-919 WAC for physicians. The CR 101 or pre-proposal statement of inquiry was filed as WSR number 25-10-039 on April 30th, 2025. Ms. Boyd, please present our proposed timeline for room development.
Thank you. So here's our proposed timeline for this rulemaking, which may be adjusted as workshops are held. If there are any questions about this timeline, so are there any questions about this timeline? Sorry, my script is all weird. Doesn't look like it.
Anything else, Ms. Boyd, that you need to mention?
Not during this part. Nope.
Okay. Well, thanks, Ms. Boyd. Please proceed with the presentation about the prescription monitoring program and tapering considerations.
that all set up. Okay, so at a previous workshop, we talked briefly about the prescription monitoring program section of our rules. So we're going to focus a little bit on that particular subsection today. And so here's our authority when it comes to that particular section. So we may determine when the PMP should be checked and that no statute specifies when PMP checks are required. And then right now, our the MDs and PAs must check the PMP before prescribing an opioid or medication listed in WAC 246, 919, 970 at the following intervals: at the first refill or renewal for acute non-operative or acute perioperative pain, at the transition from acute to subacute pain, and at the transition from subacute to chronic pain. And then currently in our rule, for chronic pain patients, the PMP must be checked for high-risk patients at least quarterly, for moderate-risk patients at least semi-annually, and for low-risk patients at least annually. And then there are a couple of other required checks, which are immediately upon identifying aberrant behavior in a chronic pain patient, or when providing episodic care to a patient already on chronic opioid therapy. So we can make some revisions. We have talked in the past about removing the references to high, moderate, and low risk, like removing those definitions and not referring to those levels of risk anymore. And then the rules will be updated to make it clear when prescribers should check the PMP outside of these particular risk levels. And then this might include something in setting new consistent timeframes for PMP queries so all chronic pain patients are monitored, while making the process simpler for MDs. And that's something that you can discuss today, making those changes in the PMP section. Let me hop over to the PMP section so you can see what it says right now. Just a second. Okay, so right now the PMP says this, and these are the times when we're supposed to, or when prescribers are supposed to check. So you can make changes to this particular rule. Let me pull up something real quick. Okay. And if you want, we can talk about this in the actual, well, let me get to there first. The actual draft language. Sorry, I have to scroll a bit. Okay. So can you all see the draft language now on the screen? Yes, no.
Yep, I can.
Okay.
We can see
Perfect.
it. It's a little challenging with the blue on the black, but
I
yeah,
apologize. That's just
yeah.
how it makes it easier for me to see. So we have already made some proposed changes to this particular, I don't know, hold on, I don't know why I did that. This particular section. And so we can talk about changing, what we really want to talk about today, I think, is changing when it should be checked. We do have some additional language that has been added to make some clarifications, but I think one of the big asks has been to change when it should be checked. And so that's what I think we need to talk about today. Let me. So Micah is suggesting we remove this subsection 4 because it talks about the high risk, the moderate, and the low risk patient.
Maybe Micah could chat to us about it.
I don't
or
think he's here.
not.
I think he. Oh, there he is.
Okay.
He is here. Go ahead, Micah.
Fresh out of the 80-degree heat and humidity in DC. So yeah, this is an edit that is consistent with some of the other proposed edits within the previous section of the rule. And so one thing that was raised to us was the high, medium, low risk conditions, with the aspect of potentially exempting chronic pain patients who are compliant and on a stable and non-escalating dose for more than 6 months, which would be the criteria for the exemption as proposed at this point. Having the risk ranges would not be necessary for this particular section. The other piece, just to give some background, that's above this, talking about limited access, is just a result of our engaging with various agencies and researchers who want access to the data but legally don't have it. It's already presented that way to some extent in the actual law for the PMP. And in this last go around, it took the Attorney General making a ruling that a certain state agency did not have the right to access the data. It would just that section add would just be clarifying that in our rules that we don't provide the data, and it's secured from only people, only folks that are law enforcement, or in the case of, say, the Medical Commission, quasi law enforcement or licensing agency would have access.
Thank you, Micah. So, commissioners, how do you feel about taking out this requirement to check at certain intervals?
I mean, I'd like to hear more comments about it. I mean, it seems reasonable, but I don't know for sure, right? So did we had problems before with the old system? People didn't like it. Is it who didn't like it? I mean, it's a burden on the patient plus the practitioner.
Mm-hmm. Right.
So I'll just chime in real quick. The feedback that we've gotten, and I'll encourage Rose or Cindy if they're on here or Maria, is that the checking is kind of arbitrary. It's based off of that risk score, not actually on who you are as a patient, what your behavior is, your response to the opioids. And so what you get is every 30 days you come in, you get your pills counted, you take your specimen test, and you get your PMP check. And so obviously some patients might need that more than others, and so that's really the feedback that we've gotten. I see Rose has her hand up.
Go ahead, Rose.
Hey, yeah, part of the issue is that this is a little bit overly prescriptive. Like, at the end of the day, when a practitioner is seeing a patient, they're either concerned about risk or they're relatively comfortable about risk. Are they low risk? Are they medium risk? Are they high risk just because of the dose they're on, even though they've got no history of aberrant behavior? Like, the physician should be able to tell, like, hey, I have concerns, I'm going to check this as often as I think it's appropriate, or this is a patient I have a long history with, nothing, they are stable, nothing has changed, I'm comfortable. I don't need to check this every 5 minutes. I need to check it periodically, just to make sure I'm checking it. But this level of, like, here's the checklist, what day is it, what patient is this, they are above or below this arbitrary dose that, again, is literally an arbitrary dose. out of the blue based on no scientific data whatsoever, check the PDMP 37 times. Like, it's just overly prescriptive for practitioners, and it becomes time consuming and problematic for patients as well at the end.
There are a bunch of comments. I think it'd be easier for us to have you raise your hand and Ms. Boyd can call on you.
So one of the comments was just asking where the exemption for long-term stable chronic pain is located. And we may get to that today, we may not. So, and then Maria was just saying that it can be discussed during the exemption section, but I don't know if we'll get to that part today. So because we are focusing on the PMP and then the tapering considerations, and then whatever time is left, then we'll start in at the beginning of the draft language, because there have been some changes since we discussed it 2 workshops ago. But yeah, that's only time permitting. Let's see. Go ahead, Carol. Or Jason. Carol, Jason.
The only thing I would say is if this isn't going to be in the exemptions for long-term chronic stable patients, then I do think it's important to keep it in, because it's difficult for someone who has chronic pain and it's long-term and it's not going to get better. Having to go in monthly it's just a lot of work, and it's a lot of time, and it's expensive. So I just would like to be heard that it does make a difference, high risk, low risk, that is somewhere, whether it's in the exemption section or in this section, it needs to be somewhere.
Got it.
Sorry, for clarity, was that last speaker talking about the exemption needs to be somewhere, or the PDMP frequency check needs to be somewhere?
What I'm saying is
this
is already in there, that for chronic pain management, the physician has the option to, this is a person who's not high risk. I can prescribe this for, 4 months or for 12 months without a concern. And if you take this out of this section, all I'm saying is currently there's no exemption in the current rule. I thought there was. I thought Micah Matthews, I thought he had said there was an exemption for it. And that was a question I had asked on the chat. And I'm told there is no exemption. So all I am saying is, if an exemption is not added in, then this should stay, because it's necessary. It's necessary for people who are stable, but they're long-term chronic pain. They're going to need opioids for a long time. They need to have this in there. It just makes life easier.
Carol, this is Rose. Let me just clarify. This is to make those patients' lives easier, to remove these finite definitions of low, medium, high. And the exemption is coming. That's part of the work we're doing here. So removing this is part of clearing the way to get the exemption language in here. So don't worry about that.
So that is what, in essence, that's what I'm saying. If there's an exemption, then take this out. So
yep, got it.
Okay. Any other comments on this? And then if none, commissioners, if you could just talk about whether you want to remove this or not.
This is Dr. Chang. Certainly there's no clear definitions of this three-tier systems. This all, based on it's a practitioner conditions, usually based on condition judgment. The high risk usually means is that, yeah, you had to kind of watch it because there's comorbid conditions and you worry about, potentially drug interactions, overdosing and so forth. And I agree that this is, this is over prescriptive, that make it simpler would be a lot easier. So basically taking out the, risk, classification would be helpful, of simply just making a stable condition, stable chronic patients that you're managing. I still think there's value for a PMP query. Simply just that this is part of the clinician doing due diligence checking. Just make sure that there are no other source of opioid medication, and then if there are, they can follow through and kind of review that with the patient or discuss it with the patient.
So there will still be there's still this requirement that they do a query if there's apparent behavior that's found. So there still is that. Go ahead, Micah.
Yeah, I'll just point out there are PMP checks required all throughout, starting from acute going through chronic, but especially the transitions from acute to subacute and then subacute to chronic. And then you've got that current sub 5, which talks about if any aberrant behavior is identified. So there are still mandated checks. There's just not as many of them, and they're not focused on the chronic pain patient.
Does that answer your question, Dr.
Yeah,
Chang?
yeah, and that's fine. And yeah, I agree that to simplify the risk stratification, this would be a lot easier. Because with this so descriptive, certainly sometimes in my practice state, I actually have high risk patient, but they're traveling and they go down to, um, from say Arizona, for winters, but then to make they had to make a requirement, they had to have a meeting and a visit with this virtual or the actual office visit, and they have to have a PMP check. That just makes it very cumbersome.
So my overall feeling is that you're fine with removing this sub 4.
Yeah, I'm
Correct.
fine with removing it.
Okay. Because we still have those other things in place.
Madam Chair, this is Ed. May I speak?
Yes, go right ahead.
Yeah. So while I support the notion and principle that we should moderate the amount of PMP checks that seem to come often, I also want to point out the other side of a clinical coin, which is, as Dr. Chang has already pointed out, and other circumstances whereby patients travel or they get opioids from other sources. And I think that as long as as long as prescribers have the ability or are not hamstrung or tied, that they are unable to check when they feel it is appropriate, and whatever that may be, whatever frequency that may be, to check the PMP, then I want to make sure that we can write it in a way or exempt something or take something out that does not allow the prescriber or does not make the prescriber feel like they can't check the PMP when they need to. That's all. And if it's coming in sub 5 or other location within the rules, then I'm really okay with the change.
Yeah, I agree with Ed about that because it should be the physician's, decision whether or not to check it if it's needed. I've seen circumstances where where, you know, another provider may be initiating a benzodiazepine, for instance, and it's unknown to the pain specialist. And that, you know, you'd think the patient might tell them that, but they may not. So I think you'd like to give the physicians a little decision ability, making ability in that. It's part of their job.
So I don't think that now or in the proposed rule that we're restricting them from checking it when they would like, not to my knowledge anyway. I would assume that if a physician decides they want to check it every time they prescribe to the patient, I mean, I think that's up to them. I mean, Micah, maybe you can speak to that a little more, but as far as I know, there's no restriction on how often they can check the PMP on a patient.
No, so just from a global perspective, you know, these are not the only rules in play when it comes to the PMP. I don't want to say that you've got the more looser set of rules, but you have less mandated checks than I would say. I think the nursing board has an every prescription standard, if I remember correctly. But to Mr. Lopez's point, you know, you've got sub 6 there, which thank you, Amelia, has scrolled down to, and we have not touched the episodic or the collaborative care section where two prescribers are dealing with the same patient and needing to coordinate. I kind of look at it from a best practice. You know, if you are initiating a new prescription for a controlled substance, is the best practice currently to check the PMP with this patient, especially if it's a new patient to you, or, you know, is it, you know, a transition from subacute to chronic, or subacute to chronic? You know, that's one of those ones where it's a mandated check. But again, the best practice would be to do a PMP check because you're working that patient up as if they're presenting with a new condition. And so it really comes down to the ability, you know, you're able to delegate it to allied health personnel to do it for you. And I think there's one set of rules that says if it's integrated to the EMR, it's for every prescription, so long as that's an automated process.
That is true. Then
I didn't realize that was what we deleted. Sorry.
so I mean you can choose to leave that in here, but it does say that, I mean, it did say that if the physician is using an EMR that integrates access to the PMP into the workflow of the EMR, the physician shall ensure a PMP query is performed for all prescriptions of opioids and medications listed in WAC 246919970. So 970 is the co-prescribing section. So to Dr. Domino's point, if a patient is being co-prescribed a benzodiazepine, then it would have to be checked. I mean, you can choose to leave this in here.
Amelia Rose has her hand up.
Oh, go ahead, Rose.
Yeah, Micah, could you explain? I guess I'm not understanding in your comment where it says this represents a large workload. When it's integrated into like Epic, isn't that a relatively seamless click? Am I not understanding the large workload part of that scenario?
It's the analysis that I'm providing on there is more how many patients do they see per day? How many times does this have to happen? And I'll leave it to the clinicians who have it integrated if they can speak to that, what the workload looks like. But I'm coming from the more global perspective, systemic perspective of it's yet another administrative thing that they need to do.
Got it. Okay,
and it
thanks.
takes away clinical decision making.
That is true.
Micah, this is Dr. Chang. I did work with for integrated health system, and that was part of EMR, but it's not automatic. We still had to sign up, and so that's like a lot of extra click that we had to go in to say yes, we reviewed it, so forth. So it's not an automatic. So to say kind of have to leave this in and then trying to go up and above things that we take those out, this basically essentially kind of like contradictory, at least to me, like say, yeah, now you're requiring those doctors working with the EMR that they had to check all prescription. That just very, very challenging. It's not kind of automated seamless in the background, as you point out.
That's helpful. Thank you for the context. And I agree. If the stuff above is deleted and this gets left in, it is contradictory.
So with that being said, I'm assuming you still want to strike sub 7 because you want to strike sub 4.
I would support that, is Dr. Chan.
Yeah. Okay. Do we have any other comments about this sub 7? Okay. So real quick, while we are in this subsection, so we had a red line, that's what I'm calling the document we got from P3 and Maria Higginbotham, where I have gone through this draft language and integrated their suggestions from that red line because they made suggestions in I think almost every subsection of this area of rule. So we need to discuss this since we are in the PMP section right now. We need to discuss this suggested change from that red line, which that whole comment is in the meeting materials and it's comment number 111. I can't remember what page it starts on, but it is bookmarked in the meeting materials. So, and then I just wanted to address this statement here, automated risk scoring tools such as NARCS Care. So we can't call out any specific tools if this proposed language is accepted. And so I just want you to I will read this out loud, this suggested addition, and then just discuss whether you want to keep it or change it, what have you. So the suggested language is use of the prescription monitoring program, including automated risk scoring tools such as NARCS Care, shall not replace individualized assessment and clinical judgment. Prescribing decisions must be based on the totality of clinical information, not algorithmic thresholds. And thank you for putting in really hard words to pronounce.
Ed Lopez here. I'd like to support that language.
And I think we can, if we add it, we would need to just remove that NARCS Care, the reference to NARCS Care. I think you could just say automated risk scoring tools and not have an example.
Agreed. Because next year it'll be something different.
Oh, Rose says the legal term for AI generated opioid risk scores is, quote, clinical decision support systems. So that would be a question for Heather. Could we include that term?
Yeah, I think both of those are pretty generic in describing the system, but not a brand or a company or a certain. So that sounded like automated risk scoring tool or whatever you just said. I don't remember the exact words, but
clinical decision support systems, they're used a lot in all areas.
Yeah, so I think that's fine because it's a generalized term for a group of systems that may be different that are providing input for the physician's decision making.
So instead of saying NARCS Care, could I just put such as clinical decision support systems or change automated risk scoring tools?
The automated risk scoring tools. Okay. I mean, but people use clinical decision support systems. It's not, yeah.
So would we want to change,
I-
or does this automated risk scoring tool
I mean, I like
describe?
the automated risk scoring tools myself
Okay.
because the clinical decision support is a lot broader, and you may be using it in part of your decisions.
Agreed.
And I would
Okay.
just say, it says use of the PMP, including, but so the automated risk scoring or the support systems aren't part of the PNP. So I think it
Right.
needs to say and or, not including.
So Maria, since you're here somewhere. Nope. I thought she was here, maybe not. So she chatted earlier. So I think changing that to or instead of, oh, okay. Thank you, Sarah. Sarah says that Maria isn't feeling well. Yeah, she hasn't been feeling well for a while. So, okay. And so I think we can change that to or instead of including, and then remove this reference to NARC's care. I don't know that we need this comma here now, but, and we definitely don't need to spell out PMP because it's in the section.
Hey, this is Rose. While we're in this section, we'd like to propose one other related change in here.
Okay.
Can we add any AI generated risk scores shall not be from these systems shall not be recorded in the patient record or override clinical judgment?
So
I'm kind of against that. I mean, people use scoring systems all the time. It comes into a factor in decision making and is part of the evidence in creating a factor or your decision. It
So
supports it. So
the scores are not in use in our state at this time. If they ever were to come into use in our state, they'd be available in, NARC's care at any time. We're just concerned because we've seen in other states where once there's a number assigned, any like actual thought about all of the other factors that factor into the clinical decision making get thrown out the window because a physician doesn't feel like they can defend against, well, here's a number that's a little bit moderately scary, but I can defend it based on the patient record and history, that number is going to make me look bad if I continue to prescribe to this patient. So we're just saying it shouldn't override the clinical judgment, which it shouldn't. And there's no need for it to be in the patient record because it's already up in NARC's care in the PDMP if it were ever implemented, which it currently isn't. We're just saying we'd like there to be a note that says no physician should let that score override their clinical judgment.
So my question on that would be to Heather, can we put a restriction for doctors to not put something in a record?
Yeah, I need to think about that, but I would, yeah, I would think that the physician needs to put in the record what they want to put in the record and detail how their decision making came about. If they use a system, then I would think that would be an important piece.
So this is Dr. Cham thinking, just seeing past when we reviewed the cases of when the clinicians were alleged to say overprescribing. Certainly when in their chart, if there's detailed documents that how they come to a decision, including using the automated, kind of risk, tool, it's actually is in the physician's favor versus there's no information. So when there's no, kind of information like that, so that you use a tool and so forth, you may potentially end up to say they come to a final decisions that this they may be practicing below standard of care. So this is why I'm kind of cautiously against the say not having the risk scoring tool. It's actually, in a way, it's more like a protective to the physician when they have to defend themselves rather than working against them when they're being reported to the commission.
So I
I'd
think
like-
Rose. Oh, go ahead, Ed. Go ahead, Ed.
No, I understand what Rose is pointing out. Certainly understand that, but I also would like to say that from a medical legal standpoint, it is, I don't think, certainly in most, if not all cases that have come up, and even during the process of reviewing a case in the commission, that anyone that I'm aware of would supersede the thought that said, well, the doctor made or the PA made this decision, but the numbers did this decision, and we're going to go with the number. I think that we still live in a world, as far as I can think of, where while there may be numeric numbers, for instance, a CBC that shows that there was a white count of 15,000, which is abnormally high, but yet the clinician decided perhaps not to start them on antibiotics, that there would be support on behalf of the listener or the reviewer that said, well, that was part of the decision making, but it wasn't the only piece that the physician or the provider made their decision by, that there was a big picture clinical decision making, and that just having it in the record certainly is not something that puts them at a higher risk. Maybe perhaps some would view it as such, but I would suppose or propose that it's not the highest risk in totality, that the big picture is the tools used along with clinical judgment that the provider makes the decision by, not numerical.
So I think, Rose, to your request, I think I'm going to have to just like Heather said, we'll have to do a little more research on whether we can even put something like that in rule, and then we can talk about it at like a future workshop when we've done a little more research and we're able to respond to that.
I just saying it's people, physicians often use these different scales in order to help as a component of their decision making. And it shows that it gives some, importance to what they've considered in it. So to me, yeah, I think physicians should be allowed to write what they want to write in a note, in a chart.
Yeah, I agree. Like, it does seem a little, here I am trying to be not overly prescriptive to say you can't write something in a chart. Of course you should be able to write what you want in a chart. I guess our concern is that there's a litany of reports about how unvalidated those automated tools are. And there's like a ton of law happening about they are just not valid scores. So it's a little bit moot for us because our state doesn't use them. We are not paying the vendor to flip the bit to turn on the scoring part because we've demonstrated the PDMP team it is wholly inaccurate and would be giving physicians bad data to use to calculate those scores. So it sounds like we're tabling this for now anyways, but we continue to be concerned about those scores as long as they remain unvalidated. Literally, they're not accurate and they end up with bad outcomes for patients that are not appropriate. So, but yes, I understand that this is a thorny little area, but that's where our concern comes from.
Thank you, Rose. Does anybody else have any comments about that particular piece? We will bring that one back in the future. Okay, and then just skipping back to sub 9 here, where Micah makes this suggestion that we change the shall to a should. Is everybody okay with that piece?
Yeah, I'm okay with that.
Dr. Domino?
Yes, fine.
Ed?
Agreed.
All right, I'm going to scroll a little bit, so everybody hold on. Okay, and so at the beginning of this subsection, we've added some language here that I would like for us to discuss today since we are dealing with this subsection. I'm going to read the addition. The PMP is a powerful tool for clinicians and patients, but its limitations must be understood and accepted. For these reasons, the legislature has seen fit to limit access to licensees, patients, relevant regulatory authorities, and law enforcement as the data contained within the PMP is not actionable without additional clinical data that is individualized to the specifics of the patient. How do you feel about that particular addition?
Micah wrote a comment. Micah, do you want to tell us more about it? I don't.
Sure. So that again, this is kind of a reference to some of the things that we've seen through various non-governmental researchers and some other agencies within state government who wanted to get access to the PMP and frankly didn't understand. They treated the data as if it could be actionable. They thought that if they got the PMP data and had a clinician look at it, they could identify doctor shopping or overprescribing or something like that. And as anyone here can tell you, that's just not the case. You have to have much more relevant and contextual data to actually draw any kind of a conclusion. And so placing that there, it was sort of just a placeholder to make it clear that the PMP data is just the PMP data. It's not the full picture.
And this is Heather. I would just say, I mean, I think that's informational. It's the the restrictions on who can access it are in statute, and those are very protective of that data. So this is fine. It's informational, but I don't know that it's not enforceable. It's just sort of you're going to rely on the statute to protect that data.
Thank you for that clarification.
So, excuse me, with that in mind, what are your
Fine to
suggestions for
add.
keeping it?
Yeah, sure.
Yes,
I'm
yes,
fine.
and I appreciate that.
Yes.
Thank you. Okay, I will read this next edition. It says use of the PMP must support safe, coordinated, and informed patient care. PMP data must not be used as the sole justification to withhold, taper, or discontinue treatment for patients who are stable and compliant with their treatment plan. So this edition is because we have gotten many requests to include a statement like this in our rule. What are your thoughts, commissioners?
This is Dr. Chen. I'm fine to add this.
Domino or Ed?
Yeah, I would support it as well.
Yeah, I'm okay. I mean, the decision is the physician's decision. I mean, most people just don't use a PMP alone in order to make a decision. So I'm not sure it needs to be said, but if it's a problem, I'm okay with it.
Okay. All right. Okay, so we will move on from that particular section. If everyone is good with that, do you have any other questions or comments about this subsection? Or any? All right, so we will Move on to tapering considerations. Let me get that back up. Start at the beginning, but we will quickly to where we need to go. Okay, so the current tapering considerations language can be found at that link, which you all should be able to click if you are here virtually. So I will share that screen real quick, and then we will move on to talking a little more about this particular section. We've had a request for a lot of changes in this area. So right now, the tapering considerations, and again, it's considerations, not requirements, for chronic pain says, I'm just going to read this to you guys. Not all chronic pain patients will need their opioid prescriptions tapered. Relying on medical decision-making and patient-centered treatment, the physician shall consider tapering or referral for a substance use disorder evaluation when patient requests, the patient experiences a deterioration in function or pain, the patient is non-compliant with the written agreement, other treatment modalities are indicated, there is evidence of misuse, abuse, substance use disorder, or diversion, the patient experiences a severe adverse event or overdose, there is unauthorized escalation of doses, or the patient is receiving an escalation in opioid dosage with no improvement in their pain or function. So that is what that section says now. In your materials, there are several other, there's 3 at least. Hold on, I've got to move something out of the way. There are 3 other documents that completely change that section. I'm going to navigate over to the, oops, wrong place. Okay. So we have 2, and then we have some other suggestions within the draft language itself that we can talk about. So we can, so there's a proposed document where it talks about making some changes to this section. So the first one, I just wanted to add in this information that was provided for this one. Their overview says that it requires physicians to ensure appropriate continuity of care when discontinuing opioid therapy or ending a patient relationship. Physicians must provide for referrals, reasonable notice, and documentation supporting the decision. And then the rule codifies protections against abandonment, especially for patients at risk of withdrawal, destabilization, or harm due to abrupt termination. And it reflects ethical obligations and aligns with HHS/AMA guidance. So this is, hold on, I've got to stop sharing and go find my doc. It should be in the materials. Let me go take a look. Okay. So sorry, my documents are not where I thought they would be. So revision number 3 is from that petition, that one that we just talked about. Let me share this document. So this changes that whole section that we just read. In fact, I can probably see if I can pull up line. Smaller so we can see the whole thing. Okay. So this revision, which should be in the packet, it talks about, it has some similar language, but it wants to add a whole lot more to that particular subsection. So I think what we need to do is, like, I tried to do a crosswalk within the draft language itself to make sure that all of this was captured. But it's really confusing. So I think what we need to do is, because we've only had like a week to look at the tapering sections, you can talk about these today if you want, but I think we need more time to compare them because there's there's technically 4 different ones. So if that is what you want to do, or if you would rather talk about some of these suggestions today, that I'm going to leave that up to you, but it is on the agenda, so you can talk about it. But my suggestion would be to have more time to look at all of these and compare them.
I'm fine with your suggestion, Amelia. I think the thing I liked about the old one is that it's short. And these already, it's hard, it just seemed very long. And this is even the first one. And I think I'd rather be able to sit with it in a piece of paper where I can see it better and try to have something short, because I think it's just very long. And that's only the first paragraph out of 3.
Right. And Rose, I do have that comment that you sent integrated into the draft language. I just did it today, though, so nobody has seen that.
Thank you. Yeah, we just sent it late yesterday.
Yeah,
And just for everybody, Cindy and I were looking at how can we incorporate the new stuff we're trying to get done, but not make this an incredibly long and verbose section that becomes, still more rules for physicians to try to get through. So we tried to figure out a way to distill it into a more concise, all-encompassing, like, here are the things that if your patient is compliant with their treatment plan and demonstrates ongoing benefit and functional stability and has no history of aberrant behavior or adverse events, then tapering is not appropriate, right? So yeah, we sent that along for you to look at. I agree. This is more than we can get through today, but I hope that folks can consider that version as maybe a simpler way to get the job done.
Thank you. So I'm going to real quick share.
Amelia, while you're doing that, I'm sorry. I did want to say, from a contextual standpoint, I'm out of the country at the moment, so I don't have access to the document at this time. I have read some in the past. What I am concerned about is always the first question that comes to my mind is always, what is it we are trying to fix? And so when I read the original document and the sort of 7 or 8 bullet points, it talks about what the provider, the prescriber, needs to do in order to stop or wean off an individual. It seemed reasonable. And so that's why when I heard about this proposed language, I thought, well, why do we need to fix it? So perhaps I can hear from someone, why are we fixing it, particularly with a tremendous amount of language.
I'll take that. This is Rose. So the old language, I agree, like that short list of 8 things is concise, it's clear, it's great. But the way it's positioned from the very beginning, not all patients will need to be tapered. Well, that assumes that the default is patients should be tapered. And that is, in fact, what has happened to a lot of patients that did not meet these criteria, actually, because the overwhelming atmosphere has been taper patients, get doses lower, stop prescribing wherever you can. And the net result has been a lot of harms to patients that has not been tracked. Like patient outcomes after, like I looked it up, we're dispensing 60% less prescribed opioids in Washington state than we did from the peak year of 2008. But we don't know what happened to all those patients. So if we can slightly recraft this language to keep those 8 things, which I agree are short and clear, but pitch them as some patients don't need to be tapered. I mean, that not all patients is still technically accurate, but the way it's pitched just sort of gives the impression that you should be looking to taper your patients wherever you can, where if your patients are stable, you shouldn't. So that's, I think, the intent behind trying to add the new language. But I agree that adding lots more paragraphs on top of existing good language isn't a great strategy. So hoping that the way we've recrafted it might be a little more amenable and still get the job done.
So, I mean, saying some chronic pain patients will not need their opioid prescriptions tapered. Isn't that just what just change a little bit? And I mean, the thing is, people become tolerant over time and they don't work as much. And maybe there are some people who would prefer to have it tapered. I mean, I know we hear a lot, forced tapering, but it should be a shared decision making, I think. Anyway, so I'd like to look at what you guys wrote, but to me, simpler the better. And you could take that first sentence and change it around.
We did
Put
actually.
Instead of medical decision making, it could be shared decision making, right? That gives the patient an ability to not just doctor making that decision.
So just for clarity, nothing we have put in there suggests in any way that a physician cannot or should not taper or discontinue opioids from any patient where that's appropriate. That's obviously still there. And this just says you aren't required to taper those patients. If they meet these criteria, you maybe should consider not tapering them. That's what it said before. That's what it still says. And we did just change just a few words of that first sentence, as you suggested. We just changed the first few words that said.
Oh, great.
So it's just slightly different pitch. But yes, today's not the day to go through this tooth and comb. But I think we're all trying to do the same thing here, which is give clear guidance on when it is appropriate to taper or discontinue and when it may not be. It's the when it may not be part that we don't think got enough attention previously. So we want the when to tapers to be very clear as still, but also the when not to part to have a little more visibility.
Thank you, Rose. Hold on just a second, Micah. So I just want to say a couple of things. One is that this first sentence was just added earlier this year. So it has not been in place, I think, prior to March. So just keeping that in mind. And then 2, we're trying to, our intent is to try to exempt chronic pain patients from the rules that are on like a non-escalating dose and things of that nature that are stable. That is our intent, is to try and exempt that group of chronic pain patients from these rules altogether. So this would not even apply to them if that exemption is approved as part of this rulemaking effort. I think that's probably what Micah was going to say, but
are we talking about the exemption today by any chance, or is that another day?
If we can get to it,
okay.
It depends on how far we get through, because we're going to start with the intent and scope section again, because we've had a lot of changes to that section, suggested changes to that section.
Okay.
So But that is our intention, is to exempt those chronic pain patients who this would not apply to them, right?
Right.
So
there's something key we want to tackle when we get to the exemption bit, something in the language we feel pretty strongly about, but if we get there, we get there.
Okay. So I think right now our decision is to wait, and we'll talk about tapering considerations at the next workshop. We'll make it another agenda item. So, and then you'll have more time, because I'm going to post all of those proposed tapering consideration languages to our website, and you'll have the next like month to look at those and maybe like make some notes and stuff like that. So, but yeah. Is it okay if we just like move on to the draft language now? Y'all okay with that? I'm assuming yes, because I'm hearing nothing. Okay, I am going to scroll a whole bunch, so on your hats. All right. Okay, so we are starting in the intent and scope section. There's some things that have already been approved, like this is just fixing our name. So we got a lot of suggested changes from Dr. Stanos from the last workshop. His complete comment is in the materials, and it's comment number 112. So he would like us to add in this section here where it says, all physicians should become knowledgeable about assessing patients' pain and effective methods of pain treatment, as well as become knowledgeable about the statutory requirements for prescribing opioids, including traditional opioid. Someone please pronounce that word for me. Agonists?
Agonists.
Agonists, thank you, such as hydrocodone, morphine, and tramadol, and partial agonists such as buprenorphine. And then they go on to say all physicians should become knowledgeable about co-occurring prescriptions. Accordingly, these rules have been developed to clarify the commission's position on pain control, particularly as related to the use of opioid agonists and partial agonists, analgesics, to alleviate physician uncertainty and to encourage better pain management. Now, these suggested changes, I think, are just informational. We do not put anything in the intent and scope section that we want to enforce, because whatever is in the intent and scope section is not enforceable. So you can discuss this language change today if you want, or we can leave it to a future workshop. That's completely up to you. But what are your thoughts right now on these additions?
I thought it was fine.
I would like to point out that when the term is used, all physicians should or would know that if we're going to use that spirit and the intent of that language, that we are very careful then about how much less support we give for the PMP. Because in my mind, the PMP and the language that we just heard go together.
Any of the other commissioners have comments about Ed's comment? So we have a question in the chat that says,
Yeah, hydromorphone is part of it's an opioid agonist. So it should be there. Up above, hydrocodone, morphine, and hydrocodone, hydromorphone, morphine, and hydromorphone.
oh, so we should add it.
Yeah, just add it there. And Ed, I didn't really understand what you were saying. Sorry.
Yeah, so when the language was, when they talk about all physicians should know, all physicians would know about, the correlation of what the patients are taking and how they're taking it, and somewhat a sense of responsibility by physicians knowing what their patients are taking, how they're taking it. That when we talk about somehow limiting or decreasing the frequency of the PMP, potentially, I'm saying potentially, then to me, one of the biggest tools that we have in active practice to determine the responsibility that I might have of knowing what my patients are taking, in addition to what I'm prescribing in the world of opioids, or whether they're on buprenorphine, and I'm going to go ahead and give them oxycodone. That the biggest tool that I have to know that isn't the patient, it's the PMP.
Go ahead, Micah.
Thanks for that comment, Mr. Lopez. So just to follow up on that, the PMP section number 1 allows actually requires that if you are doing episodic care, if you are knowingly prescribing something to a patient that is on an opioid regimen, you are supposed to coordinate, number 1, with the other practitioner, but number 2, you are supposed to look at the PMP. With respect to the changes that are being made, nothing prevents someone from looking at the PMP whenever they want. And so we're just setting a floor of, at a minimum, you need to be checking during these times. As I said, there's nothing that stops someone from checking it at every visit or asking their MA to run monthlies, whether they see the patient or not. So does that kind of answer some of your questions on that?
Yeah, it helps support the notion that if we're going to have language to encourage the physician provider, whatever the stripe is, PA or MD, that they don't in any way feel that, well, wait a minute, I checked 3 times this month, I better not check this month. So I want to make sure that the culture is there, that the physician and provider feels that they have the freedom to do so. So thank you for clarifying that.
Not a problem.
So are we okay with adding this language?
This is Dr. Chan. I'm okay with this.
And to be clear, this is clarification language, is that right? This isn't rules?
Right, so this is just in the intent and scope section, which there's
Okay,
nothing
thank you.
to enforce.
Thank
It's just, it's just information.
All right.
It's
I
guidance.
support this. Guidance, thank you.
Dr. Domino already said she's fine with it. Okay. So later in the intent and scope, there's some additional suggested language from Dr. Stanos. And so right now the language says the commission recognizes that controlled substances, including opioids, and then Dr. Stanos suggests that we add such as traditional agonists and partial agonists are analgesics that, and then it goes back to the regular language, may be essential in the treatment of acute, subacute, perioperative, or chronic pain due to disease, illness, trauma, or surgery. And then Dr. Stanos would like us to add and chronic pain, whether due to cancer or non-cancer origins. Are you okay with that addition? Do you have any comments about that particular piece?
To me, that sounds reasonable.
Go ahead, Rose. Thank you.
Dr. Stanos has got a number of comments where he is specifically specifying traditional agonists versus partial agonists, which is fine. does anybody know why he feels so strongly they need to be called out and differentiated throughout the rules? Is there some, like, do they operate differently medically? Is there, I mean, he mentions in a few places, both in the intent and in the rules, that physicians must be familiar with the evolving, mechanisms of how partial agonists work, and names buprenorphine specifically. And I have no problem with mentioning it as one of the opioids. Does anybody happen to know why he feels so strongly about calling out the difference between partial and full agonists here and everywhere?
I cannot answer that.
Is he on the call?
He's not.
I mean, buprenorphine's become quite popular in the treatment of chronic pain as a safer treatment. So I think he's just pointing it out, since many providers may not really understand. I think there's some misunderstanding about it. And so I think he wants to point it out. That's my point of view of it. But
I
I'm
certainly
not
think it's
him.
worth, I certainly think it's worth clarifying. I just don't know if we need it clarified in like 3 different places. I think clarify it where
I don't know, once
where
we see the red, I mean, because there are extra
Yeah.
words here, like this
Yeah.
suggested addition, chronic pain, whether due to cancer. I mean, the chronic pain due to disease, illness, trauma, and surgery. And then whether due to, I mean, then it says chronic pain, whether due to cancer or non-cancer. I think some of that little wordsmithing could, might give people a moment to look at it. Other here, it's just hard to see with the size of the print for many of us on our computers, and the red versus white on the black can be difficult to, so that's just my comment.
And this is Heather.
I mean,
Oh, go ahead.
I was going to say, I mean, this is just micromanaging the little words. I think it can be cleaned up. I think the idea is sort of the major idea of whether it should be left in or not.
Yeah, and this is Heather. Since this is the intent section, again, I think it might be worth mentioning once, but maybe not all these times. And that second red on here where it talks about cancer pain again, and not, or chronic pain, non-cancer, or I think those are words that are there but don't have a whole lot of meaning. And I think it just adds to the length of it. I don't know that you want a super wordy intent section.
No, I don't think we do, but maybe it's easier to just do it with a piece of paper or type it on it rather than here.
I hear you.
So one thing I will say is that we have talked, in workshops and outside of workshops about how long the intent and scope section is. And I think probably at a workshop, we have 3 more workshops scheduled. 2 of them are in next year. At one of those future workshops, we're going to present a totally revised intent and scope section. It's just that we receive these comments, and so you have to consider them as part of this work. And so the intent and scope section will more than likely change a lot between now and probably March. I have a feeling it's going to take that much time to get that whole section just totally revised and shortened. Again, this intent and scope section mostly is from the 1427 rules that were put together in 2017, 2018 timeframe. So, but you can still decide whether you think these additions are important or not. I mean, my feeling is that they're not important, but I will leave that up to you guys.
This is Dr. Jang. I'm just, thinking that I think I'm trying to guess what Dr. Stanlow is trying to call out is that there's still a lot of misunderstanding about the partial agonists. which is, there's carry a stigma that people thinking that it's, it used to be buprenorphine is that you need to have X waiver, and it's for, basically for treating substance abuse, substance disorder, use disorder. And, and so basically, in the past, when I mentioned that to my patients to say, you try everything else, it's not working, we should try buprenorphine. They basically just balk and say, are you thinking I'm abusing opioid? That's why want me to try that. And then they get pretty upset, and so this essentially is just like calling out that it can be used to treat, chronic pain. It's appropriate, and so there's no misunderstanding of that.
So instead of having that information in the intent and scope section, is that something we should call out later in rule? Maybe define, like it could be in the definition section. I mean, we have options.
It's kind of an educational thing, so I'm not sure where does that belong in a rule? I mean, it's more of, to me, just mentioning it, and have people might not understand. I've certainly, a lot of the patients I've seen don't understand, and I suspect there are many physicians who don't as well.
I mean, we can certainly call it out in the intent and scope as long as you guys feel that it's important to do so. So are you okay with adding this language? Go ahead, Micah. Sorry.
No, not a problem. A couple of things. So you already have in the rules section I don't know if it's a shall or a should, but there's a CME recommendation. That one is focused towards long-acting opioids. So if we wanted to, I don't want to say make it enforceable, but put it in a more logical and easy to call out section, it could be, recommended education or something like that. And, you talk about long acting opioids, methadone, and then you could throw buprenorphine in there and then, you could define it the way you're suggesting. The other thing to consider is, and I had the opportunity to present on the opioid rules to the Podiatric Medical Association a couple of weeks ago. And one thing that really stood out to me is their rules are largely similar to ours, but where we really differ is that intent section. Their intent section is maybe 4 sentences, whereas, and I'm not joking, it's incredibly short. I just assumed everyone kind of went on a narrative with theirs, but just as a placeholder, consider if it's not enforceable, what is this intent section doing? I'm a history buff when it comes to this, just because I've been deposed about it. And, it's interesting that there's a section of this intent that you can trace it with the Medical Commission and its predecessor organizations back to 1994. So, you've been consistent in how you've approached chronic opioid prescribing, but I'm not sure that a lengthy intent section is doing you any favors here.
Well, and to just be frank, if it's not enforceable, why would a prescriber even read this novella? You know what I mean? Like, they're probably not reading it because it's not affecting their practice. So just, keeping that in mind.
I mean, but you were saying, Amelia, we're going to go through and get rid of, cut all the language in these sections. So I just thought, just leave it there, thoughts there, and then it can be wordsmith.
Okay.
Right? Yeah.
So
I don't
that's
know.
what I will do. I will just, we'll talk about this comment that's on the right here in a second, but that's what I'll do. Whatever suggestions are in here, I will just leave them. And then when we revise this whole section, then we'll talk about them at that time. But I did want to point out this. So Dr. Sanos, right here, he wanted to add some information about buprenorphine. And I don't know if we need, like we talked about just a minute ago, I don't know if we need to add this information in the intent and scope, I don't think it's appropriate to put in the intent and scope. I mean, it is informational, but I think it would make more sense to put it somewhere farther down in the rule where it's actually stuff that they would possibly read. But it's really long.
It,
Go ahead.
yeah,
Whoever
this
was
is
about to
Heather.
talk.
So I think your rules, when you start adding in sort of this educational statement or just information, I don't think it's appropriate in a rule. I think maybe you have it on your website somewhere. It's in an FAQ. It's in a policy, but in a rule, I think we're just getting so far into the weeds that the rule should really be, these are the requirements that the physicians need to follow. This is how we're going to enforce it, and that's what the rules are for.
Agreed.
So
And we also have interpretive statements both for prescribers, and we have one for prescribers and we have one for patients. And so to me, it would make more sense to put information like this in the interpretive statement, or like you said, Heather, on our website. It doesn't make any sense to, put it in the intent and scope section for sure. So
Yeah, I think it's in those other things you suggested, and that just get it out of here.
yeah.
Should be on the website as well as an interpretive statement. And did I see some CME, if people aren't prescribing these drugs, they don't necessarily need to have CME. Docs don't like CME that are directed at a particular thing. And so I'm not a big fan of CME obligations.
So we were required in statute to require CME for any MD or PA who prescribes opioids, but that CME is only 1 hour in length. It is only a one-time situation. And then it is just about the best practices in opioid prescribing. And then just a review, like they can use any of the I can't think of the word right now, but there's different levels of help me out, Micah. What are the not a classification, it's a category. Never mind, I figured it out. Thank you. So there's categories of CME, and you can read as one of the categories. Just reading the rules, which would take probably an hour, counts as having met that requirement. So that's the only CME we have outside of that long-acting opioid one. So, I mean, we are required to have at least a little bit of CME, unfortunately. So, but that's all that's required. And many of the prescribers who have been licensed here for, farther back than 2019 have already completed that CME. So, okay. So I think we're just going to jump to the next section then, because most of the changes in the intent and scope are from Dr. Stanos. Although
So
Micah
Amelia,
does
if
have
you
the,
just take them and stick them in a document for an interpretive statement, then you have them there, and that might be a good place to hold them.
and that may be something that we do when we revise the intent and scope section, is take out some of that superfluous stuff
Yeah,
and put it in the interpretive statement instead.
yeah, great.
Micah, do you want us to talk about this with that conversation in mind? Do you want us to talk about this language from the AGO?
Yeah, I'm sorry, I'm just reviewing it real quick. Oh, right. So this is, whoops. So this is really getting at the whole, every time the CDC revises their guidelines and clinic directors and practice managers think that that is the law. And so that's why we have seen when the revision said the recommendation in the guideline was 90 MED or MME, whatever you want to say. And then I guess the most recent one was something like 50. And so consistent with whenever that thing gets released, we get complaints from patients that they are being forced to taper down to whatever the CDC says. I've personally been in receipt of pictures from clinics that have a sign out front that say, we are tapering everyone down to 90 regardless of everything. And so and the source of this is the CDC guidelines. So I believe we asked Sierra to I don't know when we asked her, but to come up with some language that would allow us to sort of state that our rules are the actual rules and they supersede anything that's not statutory or regulatory at the federal level. And so I think that's what we're considering here.
Is this still in the intent section? Because I'd like to see it in a flipping rule, if that's the
Yes.
case.
This is still in the intent section.
Yeah. And at that point, I would ask Heather where this could live.
Well, the fact that there's federal guidelines or other state guidelines that conflict, that's always going to be that if a physician is licensed in Washington, they need to follow the commission's statutes and rules. And so if those are in conflict, then you still got to follow the commission's rules. And guidelines really aren't going to have any what am I trying to say? Any value for enforcement. They are guidelines, just like our guidelines are not enforceable. Federal guidelines are not enforceable. Where you get into problems is people's like insurance coverage. Like the commission can't mandate what insurance is going to cover. That's not within their jurisdiction. So the commission can only regulate the physicians and PAs. And different clinics may have different rules, and I understand that they can't violate, the physician still can't violate the commission's rules, but I think that's where a lot of the problems come in, is there's different systems or different employers may have different expectations of their employees.
Heather.
I'm sorry?
I said thank you.
Oh, yeah. I think it's fine to place it in the intent section, or you could have, your intent section is just so voluminous that it's hard to even notice it, I guess. So you're right about that. But I think that statement is true of any, not just the prescribing rules, but any of your licensing and regulatory rules are going to supersede any other state or federal guidelines.
I mean, you guys put it in an interpretive statement with the first CDC guidelines that said, the state rules are the only rules that so you could say it again with stronger language, I guess, in another interpretive statement. But is there any way to, make it more enforceable?
No, I don't think there's any way to make it more enforceable. It is, I mean, that is how the law works, is that, and I think that it's just a misunderstanding or I don't even know what the word would be, but it's just people don't understand the hierarchy of guideline, statute, rule, guideline. I mean, all of these things, there is a hierarchy, and the physicians and PA statutes and then rules are what apply first.
Heather, I just wonder if that's common knowledge for most of our licensees. Like you and I eat, sleep, and breathe this, so we know.
Yeah.
I'm just wondering if there's a way to put it in the rules or something that's obvious, where when they get a clinic manager saying this is what we're going to do because I read the CDC guidelines and that's what it says in their federal, that they can point and say this is not true. This is what is actually carrying.
Hey, Mike, this is Dr. Chang. I can tell you that probably most clinicians are probably not aware of the differences. And, it's simply because I would say, especially nowadays, more and more of us are now employee physicians. So we actually, basically have to follow whatever our, integrated system tell us what's going on, for. And if our system operating in multiple states, and sometimes they may potentially even come out and say, well, we follow the more restrictive rules, say like a neighboring state, if Oregon has more restrictive rule, they may say, well, we just apply to all patients, we follow the more restrictive rule of that state, even if Washington say, no, this is different, so, and because we had to, practice in that environment, even if we say, well, I disagree, but then we may end up not having a job.
See, Dr. Chang, you just exposed my bias and why, maybe employment physicians aren't the greatest model.
So,
Oh
so
my
I
God,
do
yes.
note the time. It's 2:49. Are we supposed to stop now, or Demelia, do you want to have more discussion of this?
So, we typically do stop these at about 2:45 only because, we can go on for hours about this for sure. But real quick, it looks like Jeb has his hand raised. Go ahead, Jeb.
Hey everyone. Just want to make a quick general comment, and I have a question. And I wanted to make sure I got it in before we wrapped up the meeting. So if you're finished wordsmithing, I'd be happy to do that now if that's okay.
Yeah, go ahead.
Cool, thank you. So just wanted to reiterate our support for your review of these rules. We fully support modifications or a wholesale approach to these regulations that improve access to patient care. And I heard a lot of really encouraging comments today, especially around things like the intent section. So thank you for that. I have a question about the process and then a request. And the process question is, I know there's a series of workshops that are scheduled, and we've sort of been looking at this in piecemeal and with like layers and iterations of new language. And I just want to make sure that I'm tracking this correctly and that there will be stakeholder drafts that are released to sort of the broader public and physician community for their feedback before this goes to a 102.
So yes, so the way that we have to do things is at whatever the last workshop is, which may be the March one. We may hold more workshops after the March workshop. So whatever the last workshop is, and that'll be determined by whoever the panel is for that workshop. If they are fine with all of the language and they think it's ready for a 102. Then it has to go to the full commission for approval. So it will be in a business meeting packet. So however long that takes, right? However long between the last workshop and when the business meeting is, that language will be out there and available for anybody to see whatever it ends up looking like. And
Great.
then there's that 30, well, it's actually 6 or 5 weeks of comment period once there is a 102 filed prior to the hearing. So yeah, it will definitely be out there. And it will be in, for sure, it'll be on our website once that last workshop takes place, because we may get enough feedback from that finalized um, draft that we know we need to hold another workshop. So even if they approve the 102 or approve the language to go forward for a 102, we may not bring it to the business meeting to ask for that if we know that we need to have another workshop. So it will
Okay,
definitely
great.
be out there. Yeah.
Thanks for that
So-
information. I think it'll be really helpful to see everything in its totality in one before sharing with folks for feedback.
For sure.
Yeah, and Deb, I think any physicians who wish, it's hard sort of in the middle of one's workday to come and do this, but we really do want physician input
Yeah,
on
and
this.
so
Yeah.
to that end, that actually brings me to my request, and I was hoping that there might be time on the formal October agenda for WISMA to send a physician to come talk about a couple of things. One, I wasn't able to attend the last meeting, but the issue of better prescribing, better treatment came up, and I was able to listen to the recording, and there was a lot of misunderstanding about the program. And so our clinical lead, Dr. Nathan Schlicker, would be very happy to come give a presentation to sort of explain what the program's about and sort of the goals of that program. And then, while he's has that opportunity, would like to share from a physician's perspective, not mine, um, his thoughts around and WISMA's thoughts around how to approach regulations to improve access to care. If that could be an agenda item, we'd be very grateful.
Certainly, we can do that.
Great. Thank you.
Okay. Are we able to stop here?
I think it'd be a good idea. Yeah.
Yeah. Well, thanks everyone for your participation. Ms. Boyd will now outline the next steps.
All right. Let me get that pulled up. So the next steps will be the workshops that we've talked about a little bit through today. And these are when they're scheduled. And again, we will more than likely have more than just the next 3 workshops that are on the schedule. I would imagine once we get to that March workshop, we will know that we need another workshop. And so we'll start scheduling them again. And then if you have any questions or comments during that, the time between the workshops, you can always send them to medical.rules@wmc.wa.gov. And then this particular rule, well, all the rules that we have open right now, they also have a comment page on our website. So you can go directly to that page, and whatever comments are made on that page are provided at every workshop. So you can comment on that page, or you can send them directly to the medical rules email address. And then if you have any questions about this schedule, I would be happy to answer those. Like there's no questions.
All right. Any other questions about either the schedule or the rules process? See any hands raised? I don't see any.
No.
If no one else wishes to speak, I will close the workshop. Thanks so much for attending.
Thank you, everyone.